Now that I've given you an overview, I'm going to begin recording the event, and let me welcome everybody again officially to Medicaid Best Buys for 2007, Promising Reform Strategies for Governors. This event is sponsored by the Center for Healthcare Strategies and the Government Innovators Network. And I would like to begin, as we do with each event, with a poll that will give us a better sense of audience composition. So if you just click directly on your screen to the category that best represents you, and we'll give everyone a couple of seconds to answer. All right, thank you, everybody. It looks like we have a very diverse audience today. And without further ado, I'll introduce our first speaker and introducer. Stephen Goldsmith is the Dan Paul Professor of Government here at Harvard's Kennedy School of Government, as well as former mayor of Indianapolis. Mr. Mayor.
Thanks, Jim, for your help, and let me welcome everybody on behalf of CHCS and the Kennedy School at Harvard. We had really a terrific audience here, both large in terms of quality, and we appreciate your time focusing primarily attention on the Medicaid Best Buys 2007 Promising Reform Strategies for Governors. If you haven't downloaded it, you can find it on the CHCS homepage, and Jim will flash that up again, I think probably when I introduce Melanie. No, sooner than that. So you can find the paper on that site. And all of us are involved with city and state government and federal government, understand the kind of the problems facing a aging population, and particularly coupled and multiplied, if you will, by the issues of the uninsured. So the efforts of states to try to cope with this issue in creative ways is obviously terrifically important. Now, whether you're looking at SCHIP or Medicaid or managed care or the like. So what we've tried to do today is focus on some strategies that will help states produce the very best in terms of results for the dollars they spend, understanding that different policies affect different states in different ways, and there's obviously differences of policy. But if you're going to look at how we best can use the money that we have, that's the purpose of this paper. I want to particularly thank CHCS for their terrific work and their expertise in this area. And in a minute I want to introduce my friend Melanie Bella, who was a primary author of the paper. I want to thank our speakers today, and as they speak, Jim will provide you a little bit by introduction of who they are, but we have Dan Crippen, the former director of CBO. Obviously, health and how much it costs are intertwined. Diane Rowland, Executive VP of Kaiser Family Foundation. As everybody knows, the Kaiser Family Foundation is just a terrific resource for quality ideas and good thinking on these issues. Matt Salo, Director of Health and Human Services Committee for the NGA, trying to help disseminate good policies across state offices and state capitals. Alice Lind, Office Chief for Care Management and Quality Oversight for Washington State. We're pleased to have her. And Stephen Summers, President of CHCS. I'd like to next turn the I guess you will say phone instead of microphone over to Melanie Bella. Melanie has been a state Medicaid director, Harvard Business, and also worked in a public hospital and for a medical school. So she's covered the terrain in terms of medical policy. Primary author of the paper. Melanie Bella, Senior Vice President for the Center for Healthcare Strategies. Melanie.
Thank you, and thanks to all of you on this call, and I'd like to reiterate our thanks to the speakers for joining us today. We have a really full agenda, but we definitely want to save some time for questions, and also would like to say that we have some resource documents that are available on our website or will be available that will provide more information to the strategies that we will outline today. So having said that, we're all here because we care about Medicaid for one reason or another. With Medicaid serving over 50 million people at a cost of close to $300 billion, it's no surprise to anyone on this call that there is tremendous pressure on Medicaid, and Medicaid is exerting tremendous pressure on the rest of the healthcare system. There are many factors driving these pressures, including increasing numbers of uninsured, chip reauthorization, and just as recently as today, the release of the President's budget. Probably one of the most interesting twists facing us today is that this past November there were gubernatorial elections in 36 states and 2 territories, meaning that there are lots of new policymakers anxious to answer the question, is Medicaid a target or is Medicaid an opportunity? And because we believe Medicaid is a tremendous opportunity to improve care, cost, and to leverage those improvements across the system, we put together this document to help focus some short and long-term strategies for those of you interested in trying to take a quality improvement approach to sustaining your Medicaid budgets. As you will hear from our speakers, there's a common theme that goes through what we're going to be talking about today, and it has to do with addressing the highest cost, highest needs beneficiaries in the Medicaid program, because that's where the greatest opportunity lies. We see today that states as purchasers and health plans as providers have gotten much more sophisticated in their ability to use tools to better manage care. These tools range from predictive modeling to care management algorithms to clinical and social pathways to help prioritize different care patterns for the high-cost, high-needs beneficiaries. What we'll talk about today gives you a little more information about how to really go in and identify and stratify and target the people that you're serving in order to get the most effective use of your resources. What you'll also see, there is a strategy here, and it is intended to give you some short and long-term options, recognizing that there is pressure to come up with results in a fairly short time period, and that most Medicaid programs are running on an annual budget basis. We realize that you need a mix of things that offer a potential for a shorter-term payoff to help you offset some of the upfront investments that are going to be required for those things that offer you truly long-term payoff, including working with people with chronic conditions, depression, and diabetes. Those things tend to take longer, but we definitely have seen some shorter-term results in interventions targeting high-risk pregnancies, children with high-risk asthma, and congestive heart failure, because all of those things provide some fairly short-term and or immediate reductions in unnecessary and avoidable hospitalizations and ER visits. These initial successes we hope those will help you make a case for some of the longer-term investments that you'll need, as many people at the federal and state level all recognize and are calling for changes to how we all look at investments in the Medicaid program, to recognize that they must be scored, if you will, over a longer time horizon. So just to run quickly through the 5 strategies for Medicaid reform, to spend less than a minute on each, but to give you the rationale. The first 2 are the shorter-term strategies. The first one dealing with high-risk pregnancy. Medicaid covers close to half of all births in the country. Therefore, it's really important, and it's a significant opportunity to improve care for high-risk pregnant women. There are statewide care management programs that are targeted at reducing admissions for neonatal intensive care units that, again, have shown a fairly short-term payoff, definitely have shown a return on investment, and are things that states should be investigating if they don't have programs like that in place today. The second shorter-term solution is a care management program for kids, high-risk kids with asthma. Medicaid covers a third of all children in the United States. approximately 12% of those children have asthma. That gives us another great opportunity to better manage the care of those children. But I want to emphasize here that when we're talking about these types of programs, these are really targeted at children that are at the highest risk, because it is the high-risk asthmatic children that are going to offer the greatest opportunity to decrease emergency room visits and hospital admissions. The last three strategies really are longer-term strategies, and they all focus on the populations within Medicaid that have the most significant needs, both medical and social. And the theme here is getting them into some sort of system that is working with them to manage their care. Very important to note that doesn't mean that it is a, quote, managed care system, but it means it is a place in which a person feels like he or she has a medical home and that he or she is part of the care process. So the first option there, number 3, talks about managed care models for age, blind, and disabled beneficiaries. Again, no surprise to any of you, 27% of total Medicaid beneficiaries are in these eligibility groups, yet they're driving over 70% of the total expenditures. The majority of these beneficiaries are still being served in fee-for-service systems, which are relatively unmanaged, fragmented systems of care that aren't providing the best outcomes for the beneficiaries, nor are they most cost-effective for you as purchasers and providers. These are populations that benefit significantly from care coordination and from being involved in the care planning process. So we are suggesting, based on best practices and positive results seen in other states, that all states serve their age-blind disabled populations in some type of system or program that is geared at managing their care. This can be a program, the financing mechanisms of these programs can vary. It can be a full risk program, a partial risk program. It can be an enhanced case management program where providers are paid a fee for better managing the care, or it can be an administrative services arrangement. The point is that it needs to be a system of care that really manages outcomes and works on involving the beneficiary in improving his or her care. The next strategy focuses really on long-term care. In Medicaid is the largest payer of long-term care services, paying for close to 50% of that, and I know Diane will touch on that a little bit more. Most importantly, in this set of long-term care needs is a group of folks called the dual eligibles, people that are eligible for both Medicaid and Medicare. Those beneficiaries represent only 14% of people on Medicaid, yet they drive over 40% of the spending. So clearly, there is an opportunity to better manage their care in a more coordinated and cost-effective manner. You'll see that the strategies presented in this paper span a continuum. For states that are just getting started, those states may choose to manage and capitate the long-term care services covered by Medicaid. States that are a little further along may be able to integrate both acute and long-term care Medicaid services, or what we call the gold standard is true integration of Medicaid and Medicare services for dual eligibles, so that one entity is responsible for a person's total needs, ranging from the acute care needs to the long-term care services and supports, to the behavioral health and the social needs that today are covered in pretty fragmented Medicaid and Medicare systems. The outcomes that you can expect to see from programs like this include reductions in preventable hospitalizations and emergency room visits, and very importantly, an increase in community placements and an ability to serve people in their homes or in their communities in a more cost-effective manner. And last but not least, really focuses on the highest needs, highest cost, highest risk beneficiaries in Medicaid. And these are your top 1, 5, 10% of folks that are driving the majority of the expenditures in Medicaid. As a recent Kaiser report showed, and I'm sure Diane will talk about, the top 1% of Medicaid beneficiaries represented over 25% of the cost. That's astounding. And again, rather than see that as a target for short-term fixes, if you will, that try to cut services or cut those people, we really see an opportunity to apply some long-term strategies to better managing their care, and only by impacting those things that are driving the care of those populations are states really going to be able to have some control and some sustainability over their budgets. So by identifying and stratifying these high-cost, high-needs populations, states have an opportunity to really target limited resources and go after those populations that are truly impactable. So what we recommend here are a range of strategies that really at the core suggest that you focus on the top 1 to 5% of your beneficiaries to better manage their care. We're fortunate that several of our panelists will speak about these things. Diane will help us understand the overall what's going on in Medicaid and why we should focus on these high-cost, high-needs populations. Dan will talk about the pressures that Medicaid is exerting and the other pressures in the federal system, and also brings perspective from a health plan that has successfully targeted these high-cost, high-needs populations. Washington State, Alice, is a champion for us. Washington is an example of a state that's implementing strategies 3, 4, and 5. And so for those of you that don't believe it can be done, Washington is a model of what some programs other states can try. And lastly, Matt will talk to us a little bit about what pressures the governors are feeling and why it is important for governors and their health policy advisors and budget officials to consider these types of longer-term strategies in light of all the other factors going on, putting pressure on the overall system. So with that, we would like to turn it over to our speakers, and thank you again for joining us on today's call. I'm sorry, I'd like to introduce our first panelist, Diane Rowland with the Kaiser Family Foundation. Many of you have heard Diane. Diane is really an expert in the field. I think will really shed light on why we're here today and where the opportunities within Medicaid lie. Thank you, Diane.
Thank you, Melanie. It's a real pleasure to be able to join you and to share in the findings from your report and provide a little context on the high-cost populations in Medicaid. First of all, what I'd like to do is to start by reminding us all that beneath the per capita expenditures for Medicaid, there's a great deal of variation. So we're all used to seeing in Figure 1 that children and adults are far less costly than people with disabilities and the elderly in terms of per capita expenditures on Medicaid, in part driven by the long-term care expenditures of the disabled and the elderly, but also by their greater use of acute care services. But I think Figure 2 is the focus of some of what Melanie has already alluded to, the concentration of expenditures among a small share of Medicaid beneficiaries. And if we look at this slide where we analyze those who incurred more than $25,000 in medical and healthcare expenditures in a given year, we see that about 4% of the Medicaid population incurs nearly half of all spending, and those are individuals with more than $25,000 a year in expenditures. And you see there that 4% of them are really coming from people with disabilities and from the elderly. But what I want to turn to specifically in Figure 3 is that within each of the groups of Medicaid beneficiaries, we have some very high-cost cases. So it's not just the case that if you look at only people with disabilities and the elderly, that you'll capture all of your high-cost populations. Among children, less than 0.3% of children account for 17% of all spending on children. A comparable small share of adults account for 11% of all spending on adults. And another 11% of people with disabilities account for 61% of expenditures for people with disabilities, 17% of the elderly accounting for nearly 2/3 of all spending on the elderly. So regardless of what the eligibility criteria is for Medicaid, within each group there are some very high cost, high health need groups that account for a very substantial share of expenditures in those groups. It translates into it's going to take a lot of cuts to save a comparable amount of money on the relatively healthier parts of those populations than to be able to achieve just a small percentage reduction in the cost for some of your highest cost beneficiaries. If we turn to Figure 4, we can see how the high-cost beneficiaries translate in terms of the services they use. And I point out there that the main thing to look at is that we sometimes have the mistaken impression the only time that people incur high costs is when they have long-term care needs. Yet 37% of the expenditures for the high-cost enrollees that we defined as those over $25,000 a year in expenditures were for acute care services, a substantial share of that for hospital and other acute care services, but an overwhelming 8% for prescription drugs, which may lead to some to look more specifically at how to manage that part of the care delivery. And if we turn to Figure 5, we see that you can also, I know there are recommendations here on how to deal with the dual eligibles, those eligible for both Medicaid and Medicare. It is a substantial share of the population. 14% of Medicaid enrollment are dual eligibles, but before the Medicare drug benefit kicked in, we were spending 42% of all Medicaid dollars on those dual eligibles, and the prescription drug share was really only about 6% of overall Medicaid spending. So the states are still seeing a very large share of their Medicaid spending going to the long-term care, acute care needs, and payment of Medicare premiums. So this is another area where coordination with Medicare could in fact potentially have some significant savings to both programs. And finally, just because we always focus on the long-term care users, I think that we've done this new study with the Urban Institute that points out that individuals who use institutional services are not the only high-spending part of our long-term care population. While they account for 3% of Medicaid enrollees and a third of overall Medicaid spending, we are also now seeing a substantial share of Medicaid dollars going to individuals in the community who need long-term care services, and they now account for 19% of overall spending. So again, we have another way of cutting at who the high-utilizing population is. And I think as you go through your discussion today to just think about the very diverse population that Medicaid serves, the complex health needs some of these high-cost patients incur, their preterm births for children, disabled low-income adults who have very high health care costs, people with spinal cord and traumatic brain injury who count among people with disabilities, the elderly with Alzheimer's disease and other impairments are all part of the group that Medicaid really has come to be the safety net for. And it's in trying to manage the costs of that high-cost group of individuals that we have to carefully balance reducing the cost of their care against meeting their health care needs and being sure that we don't leave those who are among the frailest and sickest among us without adequate care in our cost containment efforts. So that's just a very brief overview of the dollars involved, the numbers of people involved, a small share of people, very high cost, very high health needs, and how do we balance their costs and their coverage against the realities that we now face.
Thank you very much, Diane. And I would encourage all of you on the call, if you've not seen the recent publication put out by Kaiser regarding Medicaid high beneficiaries, that you definitely take a look at that document. And just a reminder to everyone who's participating on the call, please make sure that your phone is on mute, just in case we are hearing just a little bit of background noise. Thank you again, Diane. I think despite the challenges that you laid out, you further reiterated why we view Medicaid as an opportunity, and also reminded us of the important need to balance the care needs with the pressure to contain costs. That's a great lead-in for Dan Crippen. Dan is the former director of the Congressional Budget Office. His perspective is invaluable as those of you that we are asking to go implement these strategies are inevitably being asked to demonstrate value and being asked to show a return on investment and justify why it is you should go do these things as opposed to cutting rates or cutting people or cutting services. And Dan's perspective as far as how to show value in Medicaid, understanding it as part of the overall federal spending picture and where the opportunities lie will be very helpful to us. And with that, I'm going to turn it over to Dan.
Thank you, Melanie. I will try to do some of this presentation with some dispatch. Much of it is familiar with you or to you, and I just wanted to give us kind of a common foundation for subsequent discussion. Especially these first few slides, again, maybe old news to most of you, but I'll do it anyway. The first is simply a depiction of where the federal budget has been for the last several decades. We can decry one side or the other, whether it's spending or taxes or other things, but the truth is our political system has produced a relatively stable income stream and sometimes a little too high, but nonetheless relatively stable spending stream over this long period of time.
What's crossing down then?
We've collected an average of 18% of GDP. Since World War II in federal taxes, we spent an average of around 20. Our structural deficit, rather, of something like 2% of GDP over the whole period. And we're about back to average in our current situation. So we can think about solutions, including new federal taxes to help with Medicaid, other uninsured, cost of insurance, all of those things. But just, I urge you to keep in mind kind of the historical background here of having collected 18% of GDP over a very long period of time. And as you'll see quickly, it would take considerably more than that to simply change or to simply cover the shortfall by increasing federal taxes. In fact, on the next slide, you'll see what it looks like for the federal government.
Excuse me, Dr. Crippen, if we could just pause for a second. Somebody has a lot of background noise going on. Could everyone who's not speaking please mute your phone? You can do that by pressing 6 if you don't have a mute button. Thank you. Continue, Dr. Crippen. Sorry.
Sure. The next slide, which we euphemistically call the parfait slide, shows you just for the federal government and just for the elderly what the consumption, if you will, the obligation for the federal budget looks like. And it goes from something less than 8% or a little more than 7% now to more than double that over the course of the retirement of my generation, when we go from 40 million retirees to 80 million roughly. Now, it's not surprising that you might double spending, but of course the big piece here is the increased spending on health care. Medicare being the largest, but Medicaid also contributing a significant amount over this time period. And that's largely because we expect healthcare spending to continue to increase on a per capita basis greater than economic growth. So you have both the population effect here as well as unusually high or higher than economic growth rates of healthcare costs. That in Washington is euphemistically called the excess growth. And it's been on average since Medicare and Medicaid were instituted in '65, it's been on average about 3%. That is, per capita Medicare spending has gone up on average 3% more than economic growth. So the result is a mathematical certainty. You're going to continue to absorb more of the economy for these programs. But by the time you get to 2030, you're obviously, in this projection, consuming about all we collect today in taxes. So again, to fund this gap, it would take an increase of taxes of probably 8% of GDP, some payroll taxes at the rate of 30 to 35%. So that our children, every dollar they make in wages, a third would go to supporting just these three programs. And in here is not the state share of Medicaid, and lots of other expenses that the elderly may be incurring or the kids may be financing, just the federal programs. It's not clear how you would raise taxes that much. If you tried to do it through the spending side, you would obviously eliminate most of government as we know it. If you tried to borrow your way through this, it would be in the first year $1 trillion, or the equivalent of $1 trillion in today's dollars. The next year $1 trillion plus interest, and you can see very quickly we would be within a few years consuming all of the available capital in the world in borrowing to try to close this gap. So something will change, and that's, of course, the phenomenon we're all worried about. It's what will change and how to kind of change these curves. The next few graphs depict, again, what Diane was talking about in a simplistic way. The graphs depict the concentration of spending, and whatever population you look at, it's a fairly well-known phenomenon that a relative handful of people tend to spend most of the funds. The first one shows you non-elderly spending. Again, about 20% of the population spend 80% of the dollars. The next one shows you for Medicare, the same result. The next slide is just a bar chart equivalent of the concentration, where it shows you that 5% of the Medicare beneficiaries spend about 50% of the funds. And this is, by the way, not typically concentrated in end-of-life costs. Medicare does expend about 20% of its revenues every year, its costs every year, on people who are within the last 12 months of life. But much of this is spent on people, as we will see, who have multiple chronic conditions and who live for quite some time. So it's a group of people who we can actually, hopefully, have some effect on even after they become obviously ill and require health care. Let's see, per capita Medicare. Some of the, I can tell you a lot more about Medicare than just these couple of slides, but I won't bore you with it now. These are obvious things. The folks who are in the top 25% spend a lot of money in hospitals, a lot of money with physicians and surgeries, have multiple chronic conditions, and many of them have cognitive impairment, which makes it difficult for them to comply with protocols and to kind of help themselves take care of their health care. We see that even as well in the Medicaid populations. The next slide is, again, the same image, obviously, only for the Medicaid population, where 80% of the expenditures are attributable to about 20% of the patients. Just as, in fact, I think I probably stole this from a Kaiser publication a year or so ago. So this is very similar to the kinds of things Diane was talking about. Kids and adults are relatively inexpensive and don't constitute most of the spending in Medicaid, although they constitute the lion's share of recipients. The next chart starts to drill down on who these expensive patients are. And these are the non-long-term care in this case. These are those who are getting acute care services, but they're mostly, as we will see, chronically ill patients. The distribution is very skewed. The top 1% in this 120,000 sample spends a third, 5% spends almost two-thirds. That's good news and bad news, of course. The good news is that you can actually have a manageable group of people that you might go out and work with to reduce these significant costs. As you see on the next slide, which is, I apologize, difficult to read, and we tried to put too much information on one. On the left column shows you the primary conditions and the most costly primary conditions of the most costly patients within this sample of 120,000 Medicaid recipients. So down the left side, you see cancer, chronic heart failure, asthma, diabetes, and so on. The costs, how many members out of 120,000 in this plan, the cost for them per member per month, how much of the total plan costs are concentrated, if you will, in those diseases. But equally importantly, to the right of the page, you will see comorbidities for these patients. That is, most of them suffer from 4, 5, 6 comorbidities. In the Medicare population, the most expensive group suffers from 5 comorbidities on average. They have 12 physicians, fill 50 prescriptions a year, hospitalized at least once. As we know in Medicare, no one is in charge of coordinating that care. Much the same is true of these expensive Medicaid patients on the non-long-term care costs. They have multiple conditions. Some of them are logically related. If you have kidney disease, you probably have high blood pressure. But not all of them are, nor is it obvious how their treatment should be done. I just, as an example, look at the first line of cancer. And it's obviously, in this population, the most expensive single disease. It isn't in all Medicaid populations, but it is in this one. And that probably makes some sense. And you look at at their comorbidities, and you see respiratory problems in particular, pain issues and other things. Not too surprising. But once we get behind these diseases and look at what they're actually being treated for and where, in cancer, for example, and I'll show you a little more generally, I guess it's on the next slide actually, so let's go there. The most expensive piece of cancer treatment is inpatient and emergency room. Again, may not seem too surprising on its face when you think about the number of cancers that are operable and how often we try to cut out the disease as opposed to poison it or burn it or all three. But when you look at the hospitalizations for cancer patients, you'll often find they're hospitalized not for their cancer. We turn over a cancer patient to an oncologist, hoping and charging them to cure the disease and poison it in the best way possible. Turns out oncology is only about 8 or 9% of the total cost for cancer treatment of the patient. But the oncologist, for obvious reasons, does not normally treat nor is aware of other conditions the patient might suffer from. They tend to not make sure that these patients are getting flu shots, pneumovaxes or other things. They don't treat the lung condition we saw on the previous slide. So these patients may end up in the hospital with pneumonia because we haven't paid attention to their other condition. And as Melanie and others have commiserated with us before, we're not very good in the country as a whole at taking care of these patients who have multiple conditions. In some cases, we even don't know how to take care of them. So a big challenge for all of us is to work a lot harder on what the right protocol is for these patients. But we don't have to wait forever to get those down perfectly, nor to look for opportunities to start reducing costs in this population. As you see on this slide, roughly half of all costs for these extensive conditions are hospitalizations, either ER directly or inpatient. And that, of course, is where you might want to begin to look. As we remind us occasionally, the bank robbers were, when asked why you rob banks, the answer was that because that's where the money is. Here, as you drill down on these patients, you might look at the expensive patients first, as Diana suggested, and this data suggests as well, because that's where the money is. And within their treatment, the single biggest item of cost is hospitalization. And so one thing to, one rule of thumb might be, or objective, to reduce those hospitalizations. Next slide, you see the distribution is, as I suggested, over half is hospitalization. Surgeons are 9, other physicians 10, 12. Imaging is not much, lab is even less. And you can do this, of course, for any disease, any population, and you would want to in your own Medicaid populations, and see where your best opportunities are. Nationally, pharmacy is 11% of total healthcare spend. Used to be higher for the states in Medicaid, now it's a little lower because of Part B. It's obviously always a good place to look, but it wouldn't be sufficient just to spend your time looking at something that's 10% of your total spend, even if you cut it in half. You would actually, and you wouldn't have a great impact on the total spending, and more importantly, on the out-year trends. So you need to look at what you're buying now and where you might affect that. Last thing I'll do is just as a matter of suggestion, and I apologize because these words are probably not quite right. I was just playing with them the other night. But one thing to think about as you're looking at hospitalizations is how you might categorize those you're now paying for, and therefore things you might do about it. The first one I have on here is I call unnecessary. There are a certain number of hospitalizations when you look at them that are done for convenience. It happens in the evening when a physician doesn't want to have to come into the hospital, or the family doesn't want to be bothered for a weekend. Those kinds of things. Not a lot, but there's still a significant piece of this that are simply unnecessary. People don't belong there. Preventable, an example is asthma. As Melanie said, asthma is an important condition for our Medicaid children. It's an expensive condition, as you saw in my sample of 120,000. Asthma was the second most costly condition. And it's an overstatement, but I'll make it anyway. There's no excuse that a kid ought to go to the hospital with an asthma attack. We know how to control it. We know what the right meds are. We know what the interventions are, and emergency inhalers, other things. So we're doing something wrong for most of these kids. As a result, we're incurring a lot of expense at the hospital and ER and for inpatient use, which is wholly preventable. Predictable hospitalizations, we're getting better, as I think Melanie and Diane both said, on figuring out what are the precursors to some events. you can look at a pattern of pharmacy use over a few months and see how increased use of different kinds of pharmacy and or increased use of docs and visits lead you quite directly to a hospital stay. And because we don't coordinate this care very well, the docs aren't talking to each other, and nobody's really in a position to intervene to prevent that hospitalization. But there are many cases it can be. And as I said, it's not unusual to see this pattern 6 months out from a hospitalization. And the last category I called avoidable, which is as we do more preventative care and more management of these conditions, we can keep people from having to go to the hospital. Diabetes is a pretty clear case, where with proper control and monitoring of blood sugar, we can avoid amputations and other bad outcomes for the patient and expensive outcomes for taxpayers. So there are lots of ways to think about hospitalization. In one group, one Medicaid plan rather, that this company I'm associated with took over a couple of years ago, on the first day, I sent medical directors into each of the big hospitals that were part of the plan. And they went over the medical records of every Medicaid patient in that day. And then using national standards, we determined that about 35 to 40% of those patients didn't need to be in the hospital. Some of them shouldn't have been admitted in the first place, and some had overstayed an appropriate length of time. But it gives you an idea, at least, that there is some big number. It may not be 35% in your states. It may be much less in other places, and varies hospital by hospital, I'm sure. But there's some big number of hospitalizations that even today we could avoid and not have to pay for. Over time, we're going to have to develop better protocols to take care of this growing number of multiple comorbid patients. But while that's going on, we can clearly, as the bank robbers would advise you, go to where the money is and start working on those pieces. With that, I will retire from the field.
Thank you very much, Dan. I think you, by giving us some of the Medicare context, you remind us of a very important thing, that the solutions we're talking about in Medicaid can be applied to other populations as well. So especially for those of you that are on the call that have responsibility for overall state healthcare spending, and those of you that also insure commercial populations, these are important strategies. Once we figure it out in Medicaid, I'm confident we can conquer those other populations. You also put up some really great examples of how a state or a plan can go in and look at its population and identify its high-cost patients and identify a relatively manageable group of those patients and understand what's really going on. And Washington State is an example of a state that has done that, and as a result of getting a better understanding of its patient population and understanding how to better manage that care, it has put in place or is piloting 3 different programs that Alice Lind is going to talk to you about today. So with that, Alice, I will turn it over to you.
Thank you. I'll just start with figuring out how to use your slide pointer. There we go. I'm going to be talking about 3 different pilots that we have had underway since 2002, and I want to give a little bit of the background before we get going on that. One is just to say that we have about 1 million clients enrolled in Medicaid in the state of Washington. Half of them are already in a managed care, fully capitated managed care arrangement, but the half of that population is the one that the speakers have been pointing out as the lowest cost population of Medicaid, and that is the healthy children and pregnant women or families with kids. And the other half of the population, which is completely fee-for-service until 2002, includes all of our age blind and disabled clients, all the dual eligible, all the clients who are using the most resources in the state Medicaid budget. So about 2002, we decided to launch back into managed care approaches for these populations. The first one I'll talk about is the Washington Medicaid Integration Partnership, or WMIP. That's a program that we started in 2002 with planning and a vision from our Secretary of DSHS, Dennis Braddock. He thought that one way we could start looking at avoiding poor health outcomes and high costs would be to integrate services across all the different silos of the department. so that as opposed to just doing a capitated medical services program, we would also integrate chemical dependency treatment and mental health services, and then eventually to add in the long-term care services. And so we planned and researched and looked at the population for a good couple of years before we launched it in January of 2005. And we started with just the medical and chemical dependency treatment. In October of 2005, we added in mental health services, and just a couple of months ago, we also added in long-term care. It is a one-county pilot. We contract only with one health plan, Molina Healthcare, and the program is designed to slow the progression of illness and disability through the integration of all these services. It was really the theory that by early identification of risk factors through screening and a comprehensive assessment done by a care management team, that services and the referral to those services and connection with the clients could be better managed. The enrollment in this program is voluntary, but we enroll clients by default. That is, we presumptively enroll them and then give them the information that they need to decide whether or not to stay in the program or to opt out for the most part. Some clients have to completely take action in order to get in, and those are the dual eligible clients and some Native American clients in the state. Also, the long-term care clients have to take action to come into the program so they are fully aware that they're changing the care system that they're in. What we've noticed over the course of the program is that the clients who stay in the program are somewhat different from those who opt out. So clients who have an established pattern of care and they are already familiar with the provider network that they use, etc., and have higher utilization in general, are more likely to opt out of the program than the clients who stay in. However, we have seen a stabilization of our enrollment over the course of the couple of years we've been managing it, and our current enrollment is almost 3,000. A couple of outcomes at the bottom of this slide I'll talk about in a little bit more detail. We've now operated the program long enough that we can actually see that we have improvements in a couple of things. One is that we have a drop in emergency room utilization from 128.6 per 1,000 enrollee months to 125.9 per 1,000 enrollee months. That's something that we also compare with the fee-for-service clients who have similar patterns of illness and utilization, so that we know we're doing a better job than the fee-for-service program in that respect. And then also inpatient hospitalizations have increased at a slower rate than a comparison group of like clients in the other parts of the state. We have seen some stabilization of the disenrollment of clients that was early related to some network issues of not being able to reach the complete array of providers that clients had found. And we found some results in our client satisfaction survey that also reflected that. These clients use so many different specialists, pharmacy network providers that they really rely on heavily, that any disruption in that pattern of care might cause them to opt out of this program. But on the other hand, we have seen an increase in satisfaction with the care coordination activities over time, and on some HEDIS measures, we have seen an improvement in comprehensive diabetes care. So we feel like this program is really making an impact on this age-blind disabled population. The second program that we launched in about the same time period, it was a little bit later in 2005, was the Medicare Medicaid Integration Project. And that is another program that enrolls age-blind and disabled clients, but only the dual eligible Medicare, Medicaid, and so far we are targeting the 65 and older population. This program operates in 2 counties, King and Pierce. Those are the 2 most populous counties in the state of Washington. It integrates both medical and long-term care for these clients. And because of the health plan that we work with, Evercare, they also have SNP, or Special Needs Plan status with CMS. special needs plan contracts allow health plans to target specifically the dual eligible Medicare Medicaid clients, and it puts together a special package of benefits and a special approach to those clients. The enrollment for this, because it's completely voluntary and clients have to be enrolled one by one, has to remain small. We're just about to 100 clients now. And so that is the main challenge for this program, is how do you sell this program to clients? So far in 2007, what we're working on is ramping up the enrollment together with Evercare. One of the ways that we're doing that is by expanding the long-term care provider network to include more adult family homes and other kinds of long-term care providers. And that should bring in an enrollment that is higher acuity as opposed to the healthier clients that are able to get to some of the community settings where marketing takes place. We also are right now doing some sophisticated risk adjustment on this population so that we can include the results of long-term care assessment into the way that we pay capitated rates for these folks. And then finally, to really hone in on the important quality of care measures in the population that would include the care transitions, fall prevention, dementia, and depression screening. And then finally, a brand new program that has just now started in Washington is the Chronic Care Management Program. This program, as opposed to the others, has really tried to hone in on how do you deal with the top 20%, the really high-cost clients who drive most of the care and service use in Medicaid. We have our goals here for the program and for the evaluation. The design of the program through our request for proposals this year was to try and target two new activities for these clients with chronic conditions. One was to find a vendor who would be able to use predictive modeling so that we could actually use our historical claims data to identify the clients who were most in need of care management. And secondly, to find some local vendors who would be able to get clients enrolled into a medical home and to support those medical homes in taking better care of these clients over the continuum of their illness. And so both of these contractors that you see on the slide, AmeriChoice and Seattle Aging and Disability, have just now successfully completed contracting with us. The program has just now started in February, and letters were sent on Friday to the top 20% group of clients who indicate that through their claims history that they would use high utilization of medical services over the next year. They will be offered care management services. They do have to take action in order to get into the program and to be considered active participants. And once they do agree to join, they'll have a very intensive 6-month intervention to try and educate them on their self-management, give them the links to the services they need, and then in Seattle to really buoy up that service at the medical home. So that was a quick run-through of our 3 programs in Washington, and thank you so much for your attention.
Alice, thank you very much for giving us kind of a day in the life of a Medicaid program that can tackle age-blind disabled populations, including the duals, and also really go after the high risk, in your case, the top 20%. That was very helpful, and I know states that are interested in more information about that, that you're certainly able to share that, and we can help triage those requests outside of this call. Last but not least, we have Matt Salo from the National Governors Association. I think of Matt as the expert on all things health and human services related, and so Matt, first of all, thank you for letting us drag you off the hill today, and second of all, we would love to hear from you a little bit about where the governors are in their thinking and how to accelerate efforts to target the resources in the areas we've been talking about today, specifically the highest need, highest cost Medicaid beneficiaries. And with that, Matt, thank you again for joining us.
Okay, thank you, Melanie. Again, I want to thank you and the Center for Healthcare Strategies and everybody else who worked so hard to put this together, because there's some great information here. The real benefit for going last here is that I think a lot of the really important stuff's already been said, so I'll try to sum it up real quick, and I know that people are going to want to have questions and thoughts for the discussion. So I'll just talk real briefly about sort of the overall governor's perspective. It was mentioned very early on that Medicaid can be viewed as either a target or an opportunity. I think it's funny because Medicaid is both a target and an opportunity. We know how big, we've talked about how big it is. We know that it's 20% of the average state budget. And yet, despite having been around for decades, so little has been done to make Medicaid really a modern or even futuristic healthcare system. And so I kind of consider it absolutely both a target from its budgetary perspective and an opportunity. And I think, as new governors come in and as older governors have a chance to really spend some time with the program, I do think that the more time you have in government and with experience with the Medicaid program, the more you see it becoming an opportunity. But I would say the overall perspective from governors is they're looking at 2007 and the next year or so as a real opportunity to do something exciting in healthcare. I think the perspective is that sitting around waiting for the federal government to solve things is not the answer. And so you're seeing a lot of very exciting initiatives coming out, whether it's fairly well-established ones that happen in Massachusetts, in California, Minnesota, Vermont, but an increasing number of states are trying to put together some form of comprehensive healthcare reform. They may do it in very different ways, but I think the tie that binds here is an interest in using Medicaid and SCHIP as a key piece of these coverage efforts, as an acknowledgement that for people with very severe healthcare needs or very low income, that's an absolutely fundamental part of the equation. And in fact, as you've seen all of the various state healthcare reform efforts that have been at least proposed, you will see that Medicaid and SCHIP, if not expansions, then at least reliance on these programs is a key piece. And one of the things that's interesting about that is, given the timing of today's conference call, is that the President's budget has just come out, and one of the things that we are doing is taking a look to see how is this going to impact what the states have got, what is of interest to the states, what's going to happen with respect to those various proposals. And unfortunately, we're still trying to figure out how some of this works. Some of the talk that the President the administration has done on changing the tax code with respect to how healthcare is treated is got potential. I'm not sure that it necessarily works the way it's structured, but it's got potential. And some of the talk that Secretary Leavitt has given on giving states flexibility, giving them grants and flexibility to try to structure health insurance programs for low-income individuals also is intriguing, but I think we need to figure out how exactly is this going to be paid for. And if we're going to be converting Medicaid or even potentially Medicare DISH funding or GME into insurance, that's going to be something that seems like it makes sense, but the devil is really going to be in the details for that. However, I think there are some things that are going to be not terribly helpful in the budget. There are $15 or $16 billion worth of Medicaid cuts, some of which are going to come in the form of regulations that the administration, that HHS will be coming out with, some of which we've already seen, some of which are new, such as trying to change the administrative match to 50-50 everywhere in Medicaid. And so some things that could, I think, really hold states back from trying to move forward in these endeavors. And I think this is especially concerning because trying to marshal the excitement and the opportunity that states have right now about some of these healthcare reforms is that you're going to need federal help. The state budgets right now are in a lot better shape than they have been in years, and the Medicaid budget itself within the state budget is healthier, relatively speaking, than it has been in a long time. And so I think governors see this window of opportunity opening up in the clouds to try to do something. But unfortunately, when we put on our long-term hats, our long-range vision, it's unsustainable. The state budgets are not going to continue to do as well recently as they have, and the Medicaid budgets we know are going to continue to go up in the future. So I think states are going to need, if they are going to be able to really follow through with some of these major significant healthcare advances, there's going to have to be a couple of major things done. Ideally, one of the things we've talked about is the extent to which the Medicaid budget is driven by the very high healthcare costs of people with chronic illnesses, and especially people who are dually eligible for Medicare and Medicaid, and as a big part of that, long-term care costs. Ideally, if there was some kind of major financial shift in how these programs and services are treated, acknowledging that the states can simply no longer continue to bear such a disproportionate burden of the cost of dual eligibles and of long-term care, that's, I think, critical, but in all likelihood, not terribly realistic. So given the political reality of that, the next best option is going to be allowing states to really be innovative and in trying to figure out how to best manage the care for these expensive populations. And I think what I really mean here is not so much managing cost, although that's a critical component of it, but really managing care. And so I would just reiterate some of the things that folks have said earlier, especially in Washington, about the things that managed care can bring to the table. States have started to really look, building off not only the new benefit package flexibility that was in the Deficit Reduction Act, that we see Kentucky and West Virginia and Idaho and other states looking at, but also things like trying to build upon the success of the special needs plans, or it's whether it's the things that Washington has done, or the successes that folks like Arizona that have been operating Medicaid through a entirely managed care operation for decades. And I think a lot of people talk, and again the Best Buys paper talks about how states can be laboratories for innovation, and I think that's absolutely true here. The challenges that states are going to have to overcome are that trying to build a new way of doing things for a very expensive, very fragile population is a very delicate balancing act, and it's hard to build a comprehensive network without a lot of experience amongst the doctors and all the providers and the care coordinators and the case managers. And yet, on the same hand, it's very chicken and egg, because it's hard for people to get that kind of experience. It's hard to really justify learning on the job. So, but I do think that more and more states are getting lots more experience with really trying to improve the health care that is delivered to these special needs populations. We're certainly hopeful that these types of efforts not only will improve the care, but also ultimately reduce the cost. Ultimately, we're very hopeful that improved quality will result in reduced cost, because I think fundamentally the political likelihood of major financing or financial reforms in Medicare and Medicaid are unlikely. So given that as the case, I think states are gonna have to do as best they can with what they've got, and I think that will take a lot of sharing best practices. from states like Washington and Arizona and many, many others, with the assistance of folks from the Center for Healthcare Strategies. But I also do think that even if the federal government is not going to step up to the plate in a major financial way, then we're going to have to look at things like institutional or structural reform within HHS itself to better enable the coordination between the two programs. Because currently there simply is no communication or no reliable communication between the two sides of CMS itself. And I really think that states are going to do as best they can, but they really will need help from HHS, from CMS, in order to really make that happen. So with that, I'll stop my babbling, and we're happy to turn it open to questions from other folks. Thanks, Melanie.
Matt, thank you very much. This is Steve Summers from the Center for Healthcare Strategies jumping in here, and I just wanted to thank you. Obviously, Matt has been watching Medicaid and Medicaid managed care along with us at CHS for a long time, and his observations are very accurate and right on. We were in a meeting, a couple of us, with Sarah Rosenbaum last week, a leading Medicaid legal scholar, and she studied Medicaid managed care contracts in 1995 when they were burgeoning, and she recently examined current managed care contracts and DM disease management contracts, and she couldn't help but noticing the tremendous surge in the sophistication of Medicaid purchasing, the state agency's purchasing capacity, and from risk adjustment and disease management to performance standards and quality improvement requirements, many of the things that were mentioned today. A lot of that has been done around contracting for care for moms and kids, and as all of our speakers have said, the next opportunities may be in care management for the SSI and for dual eligibles. And we recognize that an evidence base needs to be built, but that the states can't wait, and as the speakers have pointed out, it's where the money is, and so the opportunities are there, and the opportunities there to bend some of the cost trends. And I think Diane and Dan and Alice and Matt all noted that the populations that we're talking about are relatively small in size, and with the increasing sophistication of the infrastructure that states have in terms of data and predictive modeling, et cetera, the care needs and costs of this population are identifiable and stratifiable and predictable and preventable, and that's what we're pushing here and hoping that folks can take advantage of as we go forward. We have a few questions that have been submitted already, and we're going to go to them. And the first one I'm going to go to is one for Dan, which is really when you were talking about the data that you had from CBO. There was a question about, looks like it's disappeared. Are those data comparable to the ones that OMB would use or the executive branch would use? That was a question that came in, and we don't have from whom it came. Dan?
Medicare data will be now, I won't bore you with too long a story, but just to commiserate and solicit your sympathy, the federal government does not collect nor maintain routinely data on beneficiaries, patients, however you want to think about these folks. Rather, they collect and maintain lots of records on transactions. We discovered at CBO that there weren't any beneficiary level, patient level data on Medicare folks, so we took about 4 terabytes of this transaction data and actually created a database, adding up the expenditures for patients year over year. Now it's up to about 15 years because they're maintaining the database of 3 million or so Medicare beneficiaries. We, in turn, made that data set available to CMS. OMB didn't ask for it directly, but I think they do get it from CMS. And our ongoing agreement with CMS is they give us the raw data for free. They make most of you buy it. We do the meltdown and the compilation and then give it back to them in a combined data set. So both the congressional and executive branches now have a Medicare data set beneficiary level. There's some weaknesses in it. Obviously, so far there's no pharmacy data because of the newness of Part D, and we had to kind of supplement with from Express Scripts and other sources pharmacy data for another sample of elderly beneficiaries. Long way of saying OMB and CBO should have these same data sets, not to say, however, that they reach the same conclusions nor will score identically.
Okay, thank you, Dan. We have a question from Aaron, and his question was, and this is to Alice, how is Washington State trying to increase participation in the MMIE program?
Mainly the recruitment is through providers, and so the way that we are going at this is to expand the provider network. That's Evercare's work. And then the long-term care side of DSHS, along with Evercare, are also doing a lot of education with the case managers who determine eligibility for long-term care services. So they are out there in the individual home and community-based services office educating case managers about the benefits of the program so that in turn the case managers can do a better job introducing the program right at the point that clients first ask for long-term care.
Okay, we've got another one. Thank you, Alice. We've got another one that came in for, and I'm going to shoot this one to Matt. This is from Matali, and it says, the Medicaid Reform Commission submitted very good recommendations. How long would we have to wait for HHS or CMS to adopt them?
Well, that's a good question. The Medicaid Commission did submit a number of different kinds of recommendations, some of which will need legislative action, so can't really be done from HHS. But some of them are sort of recommendations that I think can be done through regulations or just through force of will. I think you saw coming out of Mark McClellan before he left a very strong interest in trying to force the Medicare and Medicaid sides of CMS to talk to each other. But honestly, you're dealing with, obviously state bureaucracy is hard enough, but I think federal bureaucracy is such that unless a very strong pressure from outside or from very, very high on top forces change and institutes the change in such a way that it can't sort of be easily ignored, then nothing permanent will happen. I think one of the things we'd love to see is something as simple as an Office of Medicare Medicaid Coordination, maybe within the Secretary's office, maybe within CMS itself. I don't know which would be the most helpful. I wonder if it wouldn't take a congressional push to make that happen. There are so many instances, and states know this all too well, of the inability of the two sides to talk. I'd love for it to happen soon, and I think they're making slow progress, but I really think that there needs to be something more drastic done to make it really relevant.
Thank you, Matt. There's a second half to that question, which actually I'm going to ask Melanie to answer offline with Natalie, because it goes into one of the specific proposals that was in the Medicaid Commission report, and Melanie might know more about where that stands. We had another question about accessing Medicare data from Amy, and how can states get access to Medicare data to assist in care management of the whole dual eligible person? I'll open that up. I assume Alice might have something on that, maybe Dan and maybe Matt. But Alice, go ahead.
Well, of course, the easiest thing to do is if you're working with managed care plans that have SNP contracts, then they control the Medicare dollar as well as the Medicaid dollar. So they have control of all the expenditures and can manage the risk all together as one integrated package. Other than that, individual agreements have been worked out between states and CMS over time to be able to get access to the Medicare data on duals, but it's not always as easy or quick turnaround as the states would hope for.
Okay, anybody else on that one, or should we move to a related question, actually? You just mentioned SNPs. We had a question about our special needs plans interested in contracting with Medicaid, and what level of awareness do we have about that? And again, Alice, and you might be able to respond, but Dan or Matt as well.
In terms of the individual health plans, we have been approached by some who have contracts for SNP status in the state, and generally we have been working with CMS through some work with the Center for Healthcare Strategies on how to improve the communication between states' plans and the CMS office so that states actually know when the planning starts, so that we can assist plans to better understand the needs of the population and that we can help prepare them for that. But the health plans who are interested in having some kind of capitated arrangement with states certainly do talk to us, and the ones who are happy to just manage the Medicare side of the dollar, sometimes we hear about it sort of secondhand through CMS or various ways.
Steve, one of the plans I work with has such a SNP. It's a dual SNP, has capitation from both sides, or from Medicare and Medicaid, all services except for mental health. Unfortunately, that's carved out in this case. But it's a 14,000 member SNP, and it works extremely well, we think. It's not just managing the financial flows, it's managing the two benefits together for a whole patient, and has proven very amenable to a medical management construct when you have both streams of revenue to work with.
Okay, and Dan, I guess you would say that there is considerable interest among SNPs based on your experience and your exposure in contracting with Medicaid for that reason.
I can't say that, Steve, because I don't know about other SNPs' attitudes about what risk they're familiar with and what risk they're willing to manage. I would think if they're amenable to managing Medicaid risk, they should be amenable to managing Medicare risk and vice versa, but I don't know that.
Okay, Melanie might respond to that question a little bit when she does her wrap-up shortly.
This is Matt. One of the things I'd throw out there on that is we're actually hearing some anecdotal evidence from some states that there is a concern that that some of the SNPs, and by and large I think the SNPs are a very exciting, very positive development, but that some of them appear to be more interested in sort of creaming the crop of some of the Medicare on the Medicare side and not really doing so much on the Medicaid side. So I think that's just it's a cautionary tale to say that even though I think SNPs are very exciting, states still need to be vigilant about how that's managed.
Okay, great. We have a question, and this is one that gets asked often by many people. What is the difference, and how can care management differ from disease management programs? And I guess that's Alice or anybody else, but that's a question that often comes up in these discussions.
Well, the main reason that we have focused on care management instead of specific disease management is that in the old program, all diabetics would be targeted for enrollment regardless of if they were high risk, low risk, or whether diabetes was the main condition driving their need for services. And in the new program, the high risk condition might be the need for mental health services or substance abuse or history of pain. And diabetes might be kind of a minor concern, but it allows the nurse to tackle the thing that is of most concern to the patient and their family and work on that, as opposed to going through the rote approach of making sure they've had their hemoglobin A1C checked in the last year.
And just to expand slightly, that there are very few vanilla-flavored diabetics, for example. Most of them do have comorbidities of various kinds, including, as just suggested, some behavioral comorbidities. We know in looking at an integrated population of behavioral and physical health that a diabetic who is also depressed and not treated will cost several times what a non-depressed diabetic will cost. But more importantly, they have these other physical comorbidities that if you treat just one, you may actually end up making the patient worse or not helping them. There aren't very many diseases that are single state. Asthma may be one exception to that. Diabetes sometimes, but not very often. But most of these folks have multiple chronic conditions, and if you treat only one at a time, you end up actually spending more money and sometimes making their condition worse off putting them in the hospital more often than necessary.
Great. I think we couldn't have chosen a better note to end on, just emphasizing the need to look at the multiple conditions and the complexities within the Medicaid patient population. We have 2 minutes left, and I've been told I'm a fast talker, so I'm going to try to wrap up what we've heard today. To go along with our 5 Best Buys, I'm going to offer you the 5 takeaways I think we heard from our speakers today. The first one is that Medicaid is the land of opportunity, and what we've talked to you about today is intended to take advantage of the opportunities as opposed to taking a more short-sighted, targeted type approach that aims at controlling Medicaid by cutting instead of controlling Medicaid by improving and better managing the care. The second is focus on high-risk populations. There are high-risk populations in your moms and kids. Those would be high-risk pregnancies and kids with serious asthma. But more importantly, over the long term, you have to go where the money goes. And those are the high-risk populations in your age-blind disabled, beneficiaries, especially the dual eligibles, and really taking a close look at the top 1% and 5% of your population. As you saw from Dan's slide, 1% of people is fairly manageable. You can identify them. You can reach out to them. As you heard from Alice, that's what Washington State has done, as it has put this program in place. And it'll be interesting to watch, Alice, how many people respond to the letter that you sent on Friday. And because I think another challenge within Medicaid is increasing our patient engagement in these programs. The third takeaway is you can launch a dual strategy. We recognize that you have a lot of pressure to show short-term results, especially financially. The strategies offered here today are intended to help you demonstrate some quicker returns while you're making the investments that are going to cost you a little bit more up front, but you're going to reap real benefit over the long haul. And the fourth is that best practices exist in these areas. States are doing these things, plans are doing these things. There's no reason not to facilitate sharing of this information. There are some great resources available from Kaiser. CHCS has resources on our webpage. Don't feel like you're going at this alone. Please look at others that have tried new things and learn from what they've done. And last, I think we heard this from everyone, states can't wait. No one can wait to begin to make the changes that we're talking about today. And not to beat a dead horse, but the greatest place to begin is in your highest cost, highest risk populations. As Diane said, you can make a little bit of a difference in the cost of that population goes a long way. And so please, as you consider cost reduction strategies going forward, please put improving quality high on your list and really focus on identifying and going after your highest risk populations. I would really like to extend thanks to our speakers today and to all of you that joined us for the past hour and a half. And just to end by saying, for more information about the things that were discussed today, you can check out the CHCS website at www.chcs.org. And there also is a spot on there for you to request specific information. You can send an email to info@chcs.org for more specific pieces of information, and we'd be happy to try to facilitate the sharing of the best practices that we've talked about today. So thank you again, and best of luck in your efforts. That concludes today's call.